it is visible, sir.
It's visible.
Yes.
There is someone. Can I change the screen?
Yes, sir. You just say next. We'll move on to
Okay.
next slide.
Thank you. I think I want to thank the organizers for the opportunity. What I am going to present is a study article published in JAMA in 2021. It's basically assessment of alectinib versus ceritinib in ALK-positive non-small cell lung cancer. It's basically had two arms. One is the comparison of phase 2 data with that of the real-world data of the ceritinib, and the other arm has real-world data of the alectinib with that of the real-world data of ceritinib. These are the patients which were basically included the patient who progressed on crizotinib. Next slide, please. So all we know that the ALK rearrangement is seen in about 3 to 5% of the patients in advanced non-small cell lung cancer. Most commonly seen in the younger age, never smokers, adenocarcinoma histology. We have almost 5 ALK targeted therapy which have been approved since 2011. There are 3 generations of ALK inhibitors which have come. This is the study which tried to look into the comparison of the 2 second generation ALK inhibitors when they progressed on first generation ALK inhibitor. Next slide. So as I was telling, there were 2 arms. One is that the one arm did compare phase 2 data of alectinib with that of the real world data of ceritinib. Other arm did compare the real world data of alectinib with that of the real world data of ceritinib. In this study, patients were monitored from June 2013 to March 2020. The group were selected from the various cancer data from United States of America, and majority of them were community centers. Participants were ALK positive, more than 18-year-old, who had previously treated with crizotinib, who had performance status of 0 to 2. Data analysis was performed from October 20 to March 2021. Next slide, please. So if you get into the data, it's actually an indirect comparison data. When they compared that the trial alectinib patient to that of the real world data ceritinib patient, that patient in trial alectinib patients were much younger. That's probably because of there is a quite difference between doing clinical trial and doing a real world data. So in the arm of clinical trial, patients were much younger compared to real world data. When they compare real world data of alectinib to that of the real world data of ceritinib, patient in alectinib group had much better performance status, and most of the patients were from the white ethnicity compared to that of the ceritinib arm. One of the reasons which they gave was it's probably because of the efficacy, toxicity cost, and ease of prescription, and also reimbursement factors might have worked for this. That was the reason given for the difference between the 2 arms. Next slide, please. The results that consistent, it showed that in alectinib group, in all the risk factors, there was a significant lower risk of all cause of death compared to that of the ceritinib group. Hazard ratio was almost 0.46. When they looked into the real world data and also in the clinical trial data, in both the groups, alectinib arm did fare better than that of the ceritinib arm, irrespective of what risk factors they had. That was the ultimate conclusion which they came out. Next slide, please. If you see the overall survival curve, there seems to be an immediate improvement in overall survival immediately after the starting of the treatment. The benefit when they compared to that of the clinical trial arm to that of the real world arm, the overall survival in ceritinib was about 14.9 months, whereas in alectinib it was about 29.1 months. But in real world data, it was much more. So ultimately, alectinib group did well compared to that of the ceritinib arm in overall survival, irrespective of the risk factors included. That was the conclusion of the study. Next slide. The discussion, as I was telling, the baseline confounding factor after adjustment, all alectinib treated patient did have a lower risk of death in all cause of mortality compared to that of the ceritinib. This was statistically significant in both trial arms, whether it was a clinical trial data or real world data. Hazard ratio from complete case analysis were also consistent with results of multiple imputation. Hazard ratio in this study were similar to that of the study previously published by Davis et al. Davis et al. Did do similar study. They did publish data in 2018. Only difference they could find between that study and this study was that in this study, the patient had much longer follow-up. That could be a little bit confounding factor, but however, overall, the hazard ratio were almost similar to that study which was published before in ALK inhibitors. Next slide. Strength of this study was this study really represented the the real data of the US population. Almost all the centers did include the patients from that. Other very important thing was that these results were also consistent when we see in the patients with Taiwan. One similar study was done in Taiwan population for the same indication. Their hazard ratio and results were also in the similar line. Limitations of this study were there were some missing data since being a retrospective analysis. There were some missing data that could have affected this thing. Other than overall survival, basically in this trial they didn't look into other aspects like toxicity and all. That could be one of the limitation of the study which authors proposed. Next slide. In conclusion, alectinib was associated with much longer overall survival compared to ceritinib. Patient who had refractory to ceritinib in ALK-positive non-small cell lung cancer. Application of quantitative-based analysis showed that there could be some biases because when they went into retrospective data, they could see that there were some missing in the performance status and comorbidity status were missing in the file. Other could be that there could be some miscalculation in the overall survival because you are comparing a clinical trial data from a single group to that of a real world data which has got much more diversity. That was one of the things the authors came out with. Ultimately, the conclusion of the study was that when compared to previous studies and all, the alectinib was much better drug in compared to ceritinib when you give a patient who has got progressed on crizotinib in ALK-positive patients, irrespective of whatever the risk factors they have got. Next slide, please.
Thank you so much, sir. For next talk, I would like to invite Dr. Preetam Kalashkar, who is a director and consultant medical oncologist at Mumbai Oncocare Center, Mumbai.